shall start my presentation by offering my humble pranam to Sathya Sai Baba. And I would like to wish you good morning to all the distinguished faculty, all the participants. Today I'm here to give you a brief introduction about the impact of IT for healthcare from a Sri Lankan background, and I'm Roshan. I'm representing University of Colombo, the Masters of Health Informatics program, as well as Health Informatics Society of Sri Lanka, which is the main health informatics partner to the Ministry of Health. So let me give you an overview of Sri Lankan health status. I mean, Sri Lanka is known for providing cost-effective healthcare free of direct cost, even before this universal health coverage concept came into the picture. And we have many health indicators in par with the developed world. We are spending around 3.2 on GDP on health, but on average we are having life expectancy at birth about 75, where the regional average is 76 and the global average is 70. And we have, as you can see, several very good health indicators, and I mean, even the things like malaria we have even eradicated in Sri Lankan setup. But I mean, the health informatics is one of the very new thing to Sri Lankan health domain. And although our indicators are very good, the health information is one of the key challenge which need improvement to ensure quality and safety in the delivery of healthcare in our context. And I mean, there was one assessment which was assisted by the WHO in 2011. In this, it was identified that Sri Lankan health informatics or the health information architecture should be modified in certain extents to support ongoing the health improvement activities, as well as to face the challenges we had with this change in the health profile, the disease dynamics kind of things. So few things the WHO has identified was HIS, Health Information System resources, for example, legislative, regulatory, planning, human resource kind of things, and the financial allocations for health information systems, and the logistics part. And the other main improvement they suggested was the indicators and the data management, because I mean, we were working on the paper-based systems, and when we in the transition process from the paper-based to the digital system, the managing of the indicators and the legislative background for the data collection and the indicator management should be different. And the information products and the dissemination and information use should also be changed according to those recommendations. And I mean, why we should take the health information or the information as a serious issue in managing the health day-to-day life health matters, or why information is important in the health domain is it has been now proved that information technology or the ICT is integral to achieving substantial quality improvement of the healthcare management by providing information for decision making start of the health administration. So that is the key concept behind the information for action, which is coined by the WHO recently. And in 2006, WHO has coined this 6 domain of quality improvement, and information is one among those 6 key areas of quality improvements in the health sector. And now I would like to take few Sri Lankan cases to explain you how those initiatives has lead to substantial quality improvement of the administrative and the care delivery process, and what are the sort of barriers in our setup which we have identified in delivering the health information to the health domain. So these three examples are EIMMR, and one of the hospital management system in a leading hospital in Sri Lanka, and the one open source project called HHIMS. So this EIMMR is an example for introducing IT to improve health information management and support evidence-based decision making at the administrative level, in the very high levels, national and the provincial level. And this hospital management system at this the major hospital is an example how this perceived benefit to the administrative layer keeps health information system sustainable in the hospital setup. Because in Sri Lanka, we don't have much sustainable electronic medical record systems. There are small initiatives, but most of these are not sustaining to the scale-up level or the institution-wide level. So, to identify what are the key factors which keeps these information system initiatives live would be a valuable task in a setup like Sri Lanka. And this open source project is one of the good example in our setup for a bottom-up IT penetration in healthcare domain, because there would be two ways basically to introduce information system in any setup, especially in developing country perspective. The top-down approach would be the most familiar, but there are a lot of initiatives which takes a bottom-up approach, but there are limitations and support for this bottom-up approach, which doesn't make the project sustainable. But what are the key things which can support the bottom-up approach would be an interesting to see, I think. So first, let's look at this EIMMR project. And IMMR, or the Indo-Morbidity and Mortality Registry, is a concept which is embedded into the Sri Lankan health setup, which is a capture of the hospital data pertaining to Indo patients from all hospital and healthcare institutions. So this doesn't include OPDs and the clinics, but all the admission and discharge we are recording in this IMMR. So this the data flow goes from the ward when the bedhead ticket was recorded, and the admission, the diagnosis will be recorded on the bedhead ticket, and from the ward, the bedhead ticket will go to the hospital record room. And there's one particular information officer in the hospital record room called Health Information Management Officer, and he or she is the responsible person to enter the diagnosis into the paper-based IMMR sheet. So quarterly, this IMMR sheet goes to the Medical Statistics Unit, which is the central unit in the Ministry of Health, and they are using these IMMR aggregates to generate annual health bulletins. And there are some shortcomings of this IMMR, the paper-based IMMR process, mainly delay in receiving returns to the central level, and some incomplete data and incomplete returns, and lack of accuracy of data, and more than everything, undue delay in annual health bulletin. Because of expansion of the health institutions and the volume of data, it was not possible to generate annual health bulletins after 2009. So all the main decisions has been taken on this annual health bulletin. So, I mean, imagine running a health system without annual statistics. So this was a major problem to Sri Lankan health setup or the health department here. So there we were able to introduce this simple system of electronic versions of IMMR, which is called eIMMR, a web-based simple system to capture aggregated hospital morbidity and mortality data based on the paper-based IMMR. So these now you can see here this all the piled up BHTs which comes to the record room in a day, and this has to be formulated to paper-based system by manual calculations previously. But now with this introduction of new system, this data can the calculation could be automated. I mean, if you see this screenshot to the right, you can see this the entire IMMR interface was very simple, and it is capturing few things like the ICD diagnosis, age, sex, place of discharge, mode of discharge, and the period of stay. Kind of a very few data elements. Those need for this administrative decisions. So the current situation of the system is now we have covered about 30% of the hospitals within about 1.5 years, and those are mainly the major hospitals. So 50% of administration we have already covered, and with the introduction of the new system within a 2 years period, now we will be able to we successfully generated after 2009 the annual health bulletin in 2013 using the eIMMR system. So this is one of the very impressive results for the ministry. So they have decided to expand the system to island-wide by year 2017, and with the health sector modernization grant we received through the World Bank. So this system will be the go online and will reach all the hospitals by 2017, and the calculation of annual health bulletin or the annual statistics will be 100% based on electronic format using this system. And I mean, not only the coverage, actually the annual or the statistics, generation of statistics is nearly real time using this system. And once the hospital administrations approve the basic statistics within the system, the statistics will be produced to the national level and will be available for the decision making level. So this is one example. Penetration of ICT had made a huge impact, the positive impact in the national level health initiative. So this is another example we thought to share with you. This is a hospital health management system of the teaching hospital Kurnaga. This hospital is the 4th largest hospital in Sri Lanka, and this is the first recorded electronic patient management system we introduced in Sri Lanka, and surprisingly it is still surviving. So that is the importance of this. The system introduced in 2003 as a isolated pilot study, which is covering about 56 wards, 10 specialized units, 6 theaters, and 50 clinics, and with the very simple functionalities. For example, patient registration, admission, transfer, discharge, lab, and pharmacy. And information to hospital management and administration was a key success behind this system. So for example, you can see now this very simple EHR model, which any EHR system is providing. But if we see the administrative support provided by the system, so we can see a few screenshots we have taken here. This system can produce the vast number of information for the administrator. For example, in Sri Lanka, the main record we are using the daily hospital administration is day and night reports. So how many patients admitted, discharged, deaths, and whether any transfers, and the midnight total was the key thing hospital administrator would like to see in managing his hospital, and including the midnight reports. And there are a lot of other reports analyzing different aspects, the diagnosis, any new issues in labs and theaters can be captured and analyzed by this system. And the former director of this hospital, we interviewed to discuss the success, the factors behind the success of this hospital. So this was a very factor he highlighted in this interview. So what the kind of administrative support he got from the system, and that's the main reason he wanted to keep this system alive. It was a solitary battle he was fighting, because at that time, around 2003, there was no other systems, and there were, no one is. At the ministry level, it was very difficult to convince to get the support for electronic medical record system. So everyone is keen on care provision process, putting everything, the money and grant everything to the drugs, lab equipments, kind of a thing. So why information system should be a major part of the hospital budget, or why information system should be maintained out of the, with the finance which they can utilize on different other care provision pathways. So that was because of this administrative support, the hospital was maintaining this the system. And now this particular director has become a deputy director general of the ministry, and now he is in the process of expanding this similar administrative support system with a newer technology, because most of this technology behind the system I have just shown is outdated, and now they're basically revamping the system with the same and more administrative support to be introduced at the administrative layer of hospital management. And this is the third project I wanted to show you, and this is very interesting project. Hospital Health Management Information System, which is an open source medical record software we have developed based on very Sri Lankan requirement. This initially the information system stores patient clinical details during outpatient visit, and replacement of the paper record is their main objective. This was one of the challenging objective, because everyone was doubted that whether they can replace the paper records, and what are the outcomes if something goes wrong when replacing the paper records. But the project took the bold decision that the major objective of the system is to replace the paper record with the totally electronic paperless system. And the medical details are entered directly into the database as a patient examined or shortly afterward, and the display an overview of patient clinical detail in the future visits, and even the labs and pharmacy. Labs test prescriptions and treatment can be ordered through the computer network. So there were various implementations, and we can see about 20 very successful implementations running totally paperless using this model. This e-hospital Dompe is one of the name of one town which this model is running. And this is one of the most successful implementation of HHIMS system, and the entire project runs in very grassroots fashion. So I selected few video clips to show this how this operates in this e-hospital Dombe project. So how first patient comes to the registration, and the nurse get the national identification number or any other identification number, and the name and the basic demographic data, and issue a card. You can see now the printer is printing the card, which is the basis of the entire health report. So this card has a barcode, and latest improvement actually, as just discussed in a previous presentation, we also the problem of identifying the same different person in the same name. So we also had include the picture in the latest versions, and so this is how patient comes to as a new visit or OPD visit. So the only thing nurse has to do is to scan the barcode, and all the detail will be queued to the doctor in the OPD. And there will be a small chip to direct the patient to the doctor's station, and in some places they have another module introduced, queue management system, so that even they have replaced this small chip. And you can see the doctors scanning the card, and all the detail and the previous visits load to the system. So doctor can examine the patient and enter the data to the system for the prescription and request for lab reports. And so this is how the process at the pharmacy level. So again they are using the same barcode card, and all the prescription is loaded to the pharmacist, and the prescription is happening based on these reports. So I mentioned this was grassroots because as for the other projects, the health information system is not a major, it is not anyway part of the national health budget. So we are not allocating any additional allocations for health information systems or even health information management. So anything we have to sustain on the grants, well-wishers, and some kind of a diverting funds to maintain this system. So the development of the system. So that is one reason why we wanted to have a national open source system, so that anyone interested can use this system free of charge, or they don't have to develop anything new. They don't have to pay for a software development entity to start a new health information system project. But any implementation assistant team can support implementation projects if there is in open source code base is available. So so there are a lot of challenges this HHIMS project and the places where this project was implemented face. For example, complexity of healthcare service process. This process should be changed for different hospitals, based on the administrative procedures and to adapt it to clinical and the other lab management, pharmacy management procedures. And the poor knowledge of IT among the health staff was a major thing. Initially, it was very challenging to train the health staff how to use even the mouse. And the poor attitude of IT among the health staff, so it is additional task at the initial steps. So they had to get familiarized with the computers, and okay, people who are comfortable with computers, they are okay with the system, but if you are not comfortable, they are putting that in a different way that it ultimately affect the implementation process. Another thing is as it was discussed now here also, the poor attitude of using IT among the patients as well, because now before in the paper-based system, the patient was the center of attention, but now this computer screen has been introduced. So here also there was various complaint that doctor is not looking at me but looking at the computer kind of things initially. But after that, after piloting this for say a few months, they actually get the idea of efficiency and how the system can make their life easy. So the community around the system actually very well motivated, and they wanted to have this kind of a health card for each member of the family, and they were keeping the card safe, and because it's a single document, they don't have to worry about the clinic books and various other things. So they laminate the card for themselves and keeping it with others, the important documents. And the top level managerial and administrative support was always a difficult task, even though like the OPD and the clinic setup, they want the system, but getting the top level administrators to convince how the system, what are the benefits of the system, why the administration should allocate finance to at least to maintain the system annually, kind of thing was very challenging at the beginning. But this was these implementations actually got very popular, I would say virally, because now few hospitals implemented, and some of the other hospitals came to visit them how the system is running, and they went to their institution and they suggested that they also should implement the system. So likewise it went in very bottom up manner, so that the bottom layer is one who took the system very positively and recommending it to the higher layers. And even there were several discussions at the ministry level that it should be recognized as a national electronic health record system. And the people who talked on behalf of the system was people who felt the benefit of the system, so that it, they discussed and they showed that the system is very helpful, not only to help the staff, but also to the clients and the patient. And the lack of funding, because of this, the bottom-up approach was a main issue. Not only to introduce a system, but main problem was now introducing actually, it's easy to fund, that is what we observe, that the well-wishers and there are a lot of people who would like to help initiating, but there were no much people to help support it running. So like computers, we need to replace the computers and all the other things like the printer cartridge and the kind of supportive things was and the network support was a major thing, and the implementers has to face because of the lack of the funding. And among these successful initiatives in Health Informatics Society and Ministry of Health and various provincial setups, we were working on so many initiatives, small, maybe small to large scale. And there are a few things we have identified in our setup. Maybe these are common to any other countries as well, especially the developing countries. One thing is that fear or hesitancy toward open source software and the open innovation process, which will have a lot of added advantage to the national very resource limited and financially restricted setups. But there are some hesitancies accepting open source. And the fragmentation of health information architecture and the unfamiliarity with the health information stewardship was another key thing we have identified. Even that was identified by the WHO also in that national assessment they did in 2011. And poor legal provisions and lack of skilled health IT workforce was other things. So hesitancy toward open source adoption was observed, and we have introduced. I mean, probably some of you may aware that there's a WHO recommended public health information framework called DHIS2. Some of the Indian institutions and Indian states also have been using this system, which is District Health Information System version 2. In Sri Lanka, we are using this for public health information capture and the supplement the clinical registries. And there are a lot of fears among especially the health administrators about these open source projects, why this comes with free of charge, what is the catch, kind of a thing. So, and the other thing is they are not very much aware that the thing called open source governance, how to acquire the open source, how to manage open source, and how to get best out of open source, kind of thing. So even though open source comes with a lot of advantages, these kind of fears and remoteness puts a barrier in such a way that we can't get best out of the open source software. And the fragmented health information architecture is another major problem in Sri Lankan setup. Now, in Sri Lanka, health systems are very independent. For example, maternal and child health is run by Family Health Bureau, and communicable disease run by epidemiology unit. So they are very protective about their data. So the information stays in silos. Family Health Bureau data they are not sharing with any other institution, kind of thing. And the poor legal provision, because most of the legal provisions or the law we have introduced with the health, the paper-based record system. For example, destroying all the health record after 5 years, kind of thing. So how that can be applicable to electronic record system. And the lack of skilled health IT force was a major thing we have identified. If we correct these, we will be able to correct, we thought we will be able to correct the other barriers also. So actually it worked, and this is some of the pass out doctors from the health masters of biomedical informatics program, which we are conducting with the technical support of University of Oslo. And so we take doctors from the ministry who are already working in the ministry, and we train them and release back to the ministry. They are the people who function as a business analyst or policy makers at the business level. So this made a huge impact. Even like the project like EIMMR was designs of our students. So with that, I would like to conclude my presentation with a thank to all of you.